Hello and welcome to the sixth video in a series of pharmacology video lessons. In this video we will mention the work of Sir James Black, a Scottish pharmacologist. In the mid-1950s, Black was studying coronary artery disease and myocardial oxygen demand. He proposed that reducing myocardial oxygen demand by annulling cardiac sympathetic drive might be an effective treatment for heart disease. By 1956, he made a goal of finding a specific adrenaline receptor antagonist. In 1988, Black was awarded the Nobel Prize in Medicine and Physiology for his discovery of the beta blocker propranolol and the H2 blocker cimetidine. For much of the mid-1960s and 1970s, propranolol and cimetidine were each number one in worldwide drug sales. In prior videos, we discussed the cardiac and vascular effects of beta-adrenergic agonists, namely tachycardia, positive inotropy, and vasodilation. Besides these cardiovascular effects, beta-agonists have also long been known to have pulmonary effects. Beta-agonists are powerful bronchodilators. In 1967, it was shown that the beta-adrenergic receptor that mediated vasodilation and bronchodilation was different from the cardiac beta-adrenergic receptor. To distinguish between these receptors, we now refer to the cardiac beta receptor as the beta-1 receptor and the pulmonary and vascular beta receptors as beta-2 receptors. In previous videos, we also discussed that the acute stress response causes the adrenal gland to release epinephrine. After reaching the heart, epinephrine binds to beta-1 adrenergic receptors that are coupled to G proteins and thus enhance the activity of adenylyl cyclase. Intracellular cyclic AMP levels then rise, protein kinase A is activated, and calcium channels located in the cell membrane and also sarcoplasmic reticulum are phosphorylated. This chemical alteration of the calcium channels then allows more calcium to enter the cell. During normal conditions, sympathetic nerves in the heart release norepinephrine, which is a primary beta-1 adrenergic receptor agonist. So therefore, the cardiac beta-1 adrenergic receptor may interact with norepinephrine that is normally locally produced in the heart, or else with epinephrine from the adrenal gland. This figure illustrates the structure of epinephrine. Recall that the N-methyl group affects beta-adrenergic receptor affinity. In the synthetic catecholamine isoproterenol, we see that an isopropyl group has been substituted for the N-methyl group. Isoproterenol has more affinity for the beta receptor than does epinephrine. The ethanolamine portion of this molecule, circled in green, is responsible for binding to the beta-adrenergic receptor, while the catechol portion of the molecule, circled in red, is responsible for activating the receptor. Medicinal chemists will often alter the chemical structure of a molecule in order to either modify drug metabolism or else to enhance therapeutic effectiveness. One common substitution is to replace a hydroxy group with a chlorine atom. In 1958, medicinal chemist at Eli Lilly synthesized dichloroisoproterenol. This drug was found to block the beta-adrenergic effects of catecholamines and became the first beta blocker. Beta blockers have affinity for the receptor, but no efficacy or intrinsic activity. If we use our lock and key metaphor, beta agonists fit the lock but do not open the lock. By occupying a receptor, beta blockers are able to block the actions of naturally occurring epinephrine and norepinephrine. James Black appreciated the clinical potential of beta blockers and while working at ICI Pharmaceuticals, synthesized pronetholol, a potent beta blocker that never made it to market because of its toxicity. Pronetholol is converted to an epoxide metabolite that was found to cause cancer in mice. However, the second drug he and his team created, propranolol, was found to be highly safe and effective. Propranolol was synthesized in 1962 and released for clinical use in 1964. Propranolol binds to beta-adrenergic receptors but has no efficacy or intrinsic activity. The suffix -olol indicates a drug is a beta blocker. Not only was propranolol a blockbuster drug in terms of sales, it is arguably the most important clinical therapeutic advance of the 20th century. Propranolol was the first drug shown to increase survival after myocardial infarction, and although originally targeted to treat heart disease, propranolol has been found to be effective in treatment of hypertension, anxiety, valvular heart disease, portal hypertension, migraine headaches, tremors, glaucoma, thyroid disease, and numerous other disorders. Beta blockers were once thought to be contraindicated in heart failure. However, in the 1990s, beta blockers were found to reduce morbidity and mortality in symptomatic congestive heart failure. This revelation has led to a complete rethinking of the pathophysiology of heart failure. This figure illustrates how beta blockers occupying the receptor are able to prevent endogenous epinephrine and norepinephrine from binding to the receptor. Note how the quote-unquote blocking effects of beta blockers differs from the blocking effects of calcium channel blockers. Also note that the administration of beta blockers is associated with lower levels of intracellular cyclic AMP and calcium, and these drugs produce negative inotropic and negative chronotropic responses. This figure represents the chemical structure of pronetholol. Note the ethanolamine structure over the green bar that is also common to isoproterenol. The same goes for the structure of propranolol illustrated here. And finally, here are the structures of several common beta blockers: alpranolol, metoprolol, propranolol, atenolol, pindolol, metoproterenol, and sotalol. Note that each of these drugs share with isoproterenol the ethanolamine portion of the molecule responsible for binding to the beta-adrenergic receptor. This brings us to the end of this video lesson. We will cover beta blockers in more detail when we discuss pulmonary and renal drugs. If you would like to see more videos, please give these videos a thumbs up and subscribe to this channel. This feedback will be important in determining whether I continue with this series of teaching lessons. Thank you.